Hello friends, today we are going to discuss a topic which we are practicing almost every day. This technique, which is evolved more than 100 years back, is still having major impact on our anesthesia practice, and it is helping us to make our patients pain-free perioperatively, whether it is an adult or a pediatric patient. Let's start the discussion about traditional techniques and modern innovations for identification of epidural space, which at times is very difficult in a seemingly thin-built patient. In first few slides, we will recognize the contribution of stalwarts of anesthesia who contributed in evolution of epidural anesthesia and analgesia, which we practice today. We will see various traditional techniques for identification of epidural space, which is the first most important step for successful epidural anesthesia and analgesia. There are few studies which compare the success rate among these techniques. We will see results of those studies. There are n number of new techniques and gadgets available in market, but used less frequently for epidural space identification. We will see some of these gadgets as it is not feasible to discuss all the techniques and all new toys for epidural space identification. Finally, I will conclude with the tips for successful epidural, as that's what matters irrespective of the technique we implement. Isaac Newton wrote in a letter dated 1675, "If I have seen further, it is by standing on the shoulders of giants." This phrase conveys the idea that one's achievements are built upon the knowledge and discoveries of those who came before. This phrase is a metaphor for intellectual progress through the accumulation of knowledge across generations. This is true for all the advances seen in anesthesia today. We must be grateful to our ancestors who worked relentlessly without much of the support for making anesthesia safe and complex surgeries possible. The neurologist Leonard Corning proposed injecting an anesthetic solution in the epidural space in the 1880s, but devoted his research primarily to subarachnoid nerve block. Despite coining the term spinal anesthesia, he may unknowingly have been investigating the epidural space. The French physician Jean Sicard and Fernand Kathleen are credited with the first intentional administration of epidural anesthesia. At the turn of the 20th century, they independently introduced single-shot caudal nerve blocks with cocaine for neurologic and genitourinary procedures, respectively. 19 years later, the Spanish surgeon Fidel Pages described a single-shot thoracolumbar approach to peridural anesthesia, identifying the epidural space through subtle tactile distinctions in ligaments. Within a decade and seemingly without the knowledge of Page's work, the Italian surgeon Achille Dogliotti popularized a reproducible loss of resistance technique to identify the epidural space. This is the man who invented the loss of resistance technique for identification of epidural space, which we all are using successfully in our practice. The Argentine surgeon Albert Gutierrez described the sign of drop, or what we commonly call hanging drop technique, for identification of the epidural space. This was not an intentional attempt, but rather accidental discovery, and credit should go for the keen observation and wonderful application by Alberto. Cuban anesthesiologist Manuel Martinez Carbello is credited with adapting Edwards to his continuous subarachnoid technique for the epidural space in 1947. His efforts were facilitated by an extensive knowledge of anatomy, a first-hand experience observing Tuhi at the Mayo Clinic, and the availability of 16-gauge Tuhi needles and small 3.5-French ureteral catheters which curved as they exited the needle tip. Apart from the 7 great men which I mentioned here, there are many more who contributed to the enormous knowledge which we possess today about epidural anesthesia and analgesia. We are always grateful to them for their contribution in the field of regional anesthesia. Coming to the techniques for identification of epidural space, there are more than 25 techniques or methods or devices mentioned in literature, some of which didn't progress beyond experimental level, while others didn't become popular enough among anesthesiologists for widespread use. I will restrict myself to most commonly used or popular traditional techniques, and these includes loss of resistance to saline or air, balloon technique, hanging drop technique, drip infusion technique, ultrasound guidance, and epidurography or fluoroscopy. Loss of resistance to air. It is the oldest and most common method followed to detect epidural space. This technique is done by filling an air into syringe and connected to the epidural needle to detect the loss of resistance. Some complications are observed by the use of loss of resistance to air. They are pneumocephalus, air embolism, insufficient analgesia, delayed onset, higher incidence of dural puncture, but still it is one of the widely used techniques. Loss of resistance to saline. Togliotti described the loss of fluid technique in epidural space. He described that while advancing the needle by exerting the pressure on the piston of syringe. Once this needle enters the epidural space, there is sensation of needle slipping, simultaneous disappearance of resistance to injection, and pressure felt on the piston of the syringe will disappear. Loss of resistance to saline is also widely used technique across the globe. This is a small video demonstrating loss of resistance to saline technique. Once the needle is inserted, you can attach a saline-filled syringe with a constant pressure on the piston. You can insert the needle, and once the needle tip enters the epidural space, there will be loss of resistance and saline will go freely inside the epidural space. So this is a commonly used technique. McIntosh proposed the use of epidural balloons in 1950. An epidural balloon consists of a small inflated balloon attached to an epidural needle. The negative pressure resulting from the tip of the needle entering the epidural space causes the balloon to collapse, thereby providing a visual indicator of loss of resistance. In this article, published in 2008, author described an innovative use of the same age-old balloon technique. A three-way, commonly available in operation theatre, is attached to the epidural needle, where the one end is having the balloon and the other end is attached to the syringe for charging the balloon. We can try this technique easily. A few years back, Ramson's company marketed this product. I am not aware about its availability today. This video shows a refined adaptation of McIntosh balloon, where instead of air, saline is used to inflate the balloon, and deflating balloon gives visual indication of needle entering into the epidural sphere. Just observe this balloon, which is filled with the saline, and once the needle enters the epidural space, now it is getting deflated. So this is another adaptation of the McIntosh balloon. Hanging drop technique. Alberto Gutierrez discovered the hanging drop technique in February 1933. He was searching for epidural space with loss of resistance to saline technique. Due to the stiff resistance, he removed loss of resistance syringe and noted a small drop of saline hanging at the tip of the needle. As he advanced the needle, the drop suddenly disappeared or moved inside the epidural space due to negative pressure of the epidural space. That's how hanging drop technique got discovered. This is a small video. Now watch closely and you will see the slow sucking in of the saline drop here into epidural space due to the negative epidural pressure which is present. Availability and accuracy provided by the ultrasound is making ultrasound guidance more popular, but it has steep learning curve. I can vouch its use particularly in obese patients. Ultrasound scan can help determine the following things. We can determine the depth to the epidural space, that is the distance from the skin to the epidural space. Optimal needle insertion site, the best location to insert the needle. So this way you can avoid the multiple pricks. Interspace level, the level of the interspace. Midline of the spine. Optimal angle for needle insertion, the best angle to insert the needle. These all points are particularly useful when surface landmarks are not palpable either, due to obesity or due to distorted anatomy, for example, in scoliosis. These are ultrasound images of caudal area. Solid arrow will indicate the needle direction to the space from S2 to S3 intervertebral level, and the dashed line, image B, arrow shows the needle direction through the sacral hiatus. The black arrows indicate the point of needle insertion. The Sonix GPS, this is the most advanced needle tracking system. The Sonix GPS system uses electromagnetic technology to track the position of a needle sensor and sensors in the ultrasound probe. It displays the needle's current and predicted position on the ultrasound screen in real time. This Sonix GPS needle tracking system, the sensor element is within disposable inner needle stylet, which keeps the needle sterile. A transmitter or a receiver unit is placed near the block site to track the sensor. This helps with needle beam alignment and guidance to the target, improved the performance of the inexperienced users. It uses proprietary needles that contain a reusable needle sensor element, and the sensor element is within disposable inner needle, which keeps the needle sterile. This Sonix GPS can be used either in-plane approach or out-of-plane approach. In in-plane guided approach, the patient is placed in a lateral position and a parasagittal oblique view of the chosen interlaminar space is obtained. The introducer needle and the sensor is inserted at the caudal end of the probe and advanced in a cephalad direction. These are the green bars. Green bars on either side of the screen indicate good needle beam alignment, and graphic of probe and needle at the bottom. So this is the right bottom corner of the screen where you can see a probe and needle. The needle trajectory is indicated by the dotted line. So this is the needle trajectory indicated by the white dotted line, is adjusted to line up with the interlaminar space. This is the one lamina, this is another lamina. So this interlaminar space you have to align. The introducer needle is indicated by the red dotted rectangular outline. So this is the red dotted rectangular outline, and it inserted until its tip lies just superficial to the lamina and ligamentum flavum dura mater complex. The probe is then put aside, the needle sensor removed from the needle, and a 120 mm spinal needle inserted in the place to penetrate the dura. This works like a blind dural puncture epidural technique. That is, if one accidentally punctures dura, then just retract the needle to point where there is no CSF flow and you can be in epidural space. But this gadget has high accuracy. Out of plane Sonix GPS guided approach. Patient is placed in a sitting position and a parasagittal oblique view of the chosen interlaminar space is obtained. So patient is sitting and you are using probe in a long axis and needle is just beside the probe. So this is a out of plane approach. The introducer needle and the sensor is inserted medial to the probe, slightly caudal to the interspace. The needle trajectory indicated by a dotted line. So this is a dotted line, and it is adjusted until the white cross. So you can here see the white cross overlies the ligamentum flavum dura mater complex. The introducer needle, which is indicated by this red dotted line, is inserted until its tip lies just superficial to the lamina and ligamentum flavum dura mater complex. The probe is then put aside, the needle sensor removed from the needle, and a 120 mm spinal needle inserted in its place to penetrate the dura. This was a feasibility study published in 2014 for assessment of Sonix GPS system for real-time ultrasound-guided spinal anesthesia, and the conclusion of this study is that the Sonix GPS system simplifies real-time ultrasound-guided spinal anesthesia to a large extent especially the out-of-plane approach. Nevertheless, it remains a complex multi-step procedure that requires time, specialized equipment, and working knowledge of spinal anatomy. This is traditional use of C-arm for epidural space identification. Patient can be sitting or prone. I personally prefer sitting position so that neck is well flexed and increases cervical epidural space dimensions. Second image shows the use of Magill forceps for C6, C7 level marking. Under continuous fluoroscopy, epidural needle is advanced and needle entry into epidural space is confirmed by injecting dye. Dye should spread vertically. So this is the vertical spread of the dye and it should remain there. Diffuse spread indicates needle tip into CSF and rapid washout of the dye means it's an intravascular injection. We will see some studies comparing the efficacy of some of these traditional and modern techniques to identify epidural space. This paper, published in 2018, compared a loss of resistance to air versus saline for epidural space identification in 400 pregnant patients. Results could not come out with the clear winner among these two techniques. This paper is the latest publication of 2023, where author Isha Singhal compared loss of resistance versus balloon technique, and author concludes that the epidural space was identified in first attempt in 95% of patients in group B, that is epidural balloon technique, versus 89% in group A, that is loss of resistance technique. To conclude, the epidural balloon is a simple, easy to use device, especially useful for inexperienced anesthesiologists for accurate identification of the epidural space in short time without any increase in the complications. This is another interesting article published in 2014 by author Suresh Singhal, where they compared loss of resistance, infusion drip, and balloon technique, and author concludes that the time taken to localize the epidural space was least in drip infusion technique. As for number of attempts, quality of the block, and complication is concerned, all the three techniques are comparable. We all love new gadgets, and technology is so advanced that we have few gadgets for epidural space identification also. And what are those gadgets? Mechanical devices such as EpiSure Auto Detect syringe. These syringes provide visual confirmation of loss of resistance. This syringe includes an internal compression spring that applies constant pressure on the plunger and automatically depresses when the needle enters the epidural space. Here one can use both the hands while visually you can confirm the loss of resistance of saline once the needle enters the epidural space. This is the publication from 2015 in which author Edward Johnson Joseph and his colleagues compared EpiSure syringe to the conventional glass syringe for identification of lower thoracic epidural space. They found that EpiSure allowed reliable and quick identification of epidural space in lower thoracic epidural as compared to use of glass syringe. There was no incidence of inadvertent dural puncture or failed blocks with the use of EpiSure Auto Detect syringe. Another similar gadget is this EpiPhase syringe. As the needle tip enters the epidural space, a rapid decrease in a pressure known as loss of resistance causes the swift movement of color indicator. So this is the color indicator to appear, signaling the end point of advancement of the needle. This strategy can be helpful to reduce the risk of accidental dura puncture. The EpiPhase syringe is mechanically driven, consistent with current practice, compatible with other accessories presently in use. However, there is sparse information in literature regarding its use and efficacy and sensitivity. This is latest device for epidural space identification and it is known as EpiDetect, which detects the negative pressure of the epidural space and notifies the anesthesiologist by flashing a light and producing a beeping sound. Easy, isn't it? Here you can see the color has changed. This is green color and this is blue color. We also have a feasibility study of EpiDetect for cervical epidural steroid injection. Authors compared Epidetect to the loss of resistance technique and found that though there are no complications in either group, Epidetect was superior in terms of operation time and it reduces the radiation exposure. Coming towards end of my presentation, take home message for successful epidural space identification will be to use optimum patient position, use of ultrasound in anticipated difficult epidurals. I personally prefer loss of resistance to saline and use paramedian approach for all epidurals with good success rate. If you get chance, then do use new gadgets irrespective of the traditional or modern techniques used. One should not forget guidelines in anticoagulated patients. And most importantly, always aspirate for blood before giving test dose of local anesthetics in epidural space. This lady weighing around 40 kg, was posted for cervical epidural steroid injection. Identified epidural space under fluoroscopy with hanging drop technique. Before injecting dye for epidurography, I aspirated, which I follow religiously, and there was frank blood. I removed needle and tried at another space with same results. We abandoned the procedure. We should not compromise safety whatever technique we use. I would like to conclude with this quote. The loss of resistance technique is not just a method, it is an art. This reflects Doglioti's contribution to identifying the epidural space and underscores the skills involved in administering epidural anesthesia safely and effectively. As shown in this cartoon by Dr. Ganesh Chaudhary, this Pushpa position will not help us for easy identification of the epidural space. So always have a good position for epidural. Thank you so much. Die.